Welcome to T's Voices, telling the stories of the people in our NHS community.
Hello and welcome back to the podcast. So I'm thrilled to have with us today our neonatal MDT team to talk about their career pathway, MDT, and the things you don't know about neonates. So can I hand it over to Jessica for an introduction?
Hello, my name's Jess. I'm part of the AHP and psychology team working in the neonatal intensive care and special care baby unit at James Cook. We are currently a 35-bedded intensive and special care service, and we care for babies born early, babies who might have been unwell, or those born with complex medical needs. Your average pregnancy would last around 40 weeks, and some babies arrive up to 17 weeks before their due date, meaning that their body systems, such as their breathing, feeding, movement, and sensory, are not yet ready for life outside of the womb. Others may be born at term but experience significant medical or neurological changes. Alongside the medical and nursing teams, as AHPs and psychology, we support babies' development at the most critical time in their lives. We try to use our expertise in early development, and we focus on preventing difficulties and optimising outcomes by harnessing neuroplasticity while the brain is rapidly developing. Early support can make a lifelong difference. Currently, 1 in 7 babies in the UK spend time on a neonatal unit, and most of them will be fine, but many will have challenges which will impact on their educational and social and also their interactional outcomes. We also work closely with families, supporting bonding, attachment and parental well-being in an unexpected and stressful journey for many of our families. Much of our work is observation, coaching and shaping the neonatal environment to be as developmentally supportive as possible, giving every baby the best possible start. I think we can say that currently no 2 days are the same.
We all work together and we all cover a lot of stuff that's very similar, but we also have our own little bits as well that bring our specialisms in. So I'm Lynn and I'm the physio. Physio has been coming onto the unit and following up babies. So once they leave the unit into the community until they're about 2 for the last 30 years. Our input is based around reducing the impact of any challenges, particularly in terms of their chest, their bones and muscles, their neurology and their sensory difficulties. I look at every baby. I come slightly different from perhaps some other staff. And when I look at every baby, no matter how early they are, and I think, what can I do today that will give them the best opportunity and choices when they're 30? I think the thing that I found most challenging when I started was putting my hands behind my back and touching, because I don't know what people think, but lots of people feel that physios traditionally a very hands-on role. So that was a real challenge for me. The babies that we look after are often really fragile, so that any touch we do needs to be really, really slow and careful. We need to support all their systems and we need to help them to regulate so we don't use up all their precious energy. And we really don't want to cause them any stress, because that is upsetting, but also can affect their brain development. I spend a lot of time ensuring the care of the babies protects their bodies and brains, and supporting parents to really understand the babies and show them what amazing skills they already have. So I might do some chest physio, but it's really, really different to chest physio that people might think of, even that on babies up in the paediatric ward. We do a lot with positioning, how to carry, how to hold, how to move. We'll do neurological and developmental assessments. We might support a baby, for example, with fragile bones to be held safely, or we might support the other staff to carry out a procedure without causing any pain or stress to the baby. And we also follow them up into the community, and we support the parents as they transition to home and ensure we continue to optimise their development. And we really work on the wonders of neuroplasticity, which is when that little brain can rewire when they're tiny. And then I'm going to talk, if people don't mind, I'm going to talk about Emma, who's our OT. Sadly, she can't be here today because she has her own little ones, but she's come onto the unit and her background is mostly in community paediatrics. So it's been really interesting to see where some of the babies that she would previously have seen start their journey and how it impacts them. And she really wants to try and support those initial days to give them the best start. Her role involves promoting babies' brain development, supporting their nervous system, their regulation, and what we call babies' occupations. So we all have occupations, and for babies, that's things like nappy changing, getting dressed, sleeping, feeding, and play. She really helps the parents and carers to interpret their baby's behaviour and supports a bond between them. And she really emphasises skin to skin and the parenting role. Before they go home, Her main aim is to give enough information for the parents and carers to really help the babies work on their sensory and motor skills and to be able to sort of regulate themselves, understand themselves and play. For all of us, it's all about their future development. I'm going to pass back to Jess.
Okay, thanks, Lynn. So, like I said, my name's Jess and I'm one of the neonatal dietitians. I have been working as a paediatric dietitian for roughly about 8 years now, and I've covered neonates for the last 5 to 6 years. Like my colleagues, I would follow babies up on the unit who may require dietetic input up to 2 years of corrected gestation. My neonatal time is split between the neonatal unit and community follow-up and review. Part of the role as the dietitian would be to optimise the growth and the development of a premature baby. This could either be through parental nutrition and more so going on to enteral nutrition, whereby a premature baby may be fed through a feeding tube until they are old enough to progress onto oral feeding. Much of the care that I do is aimed at being more proactive rather than reactive, and this could involve improving the use of mother's own milk and lactation, guiding the use of donor milk or even the fortification of breast milk, and always ensuring evidence-based practice where needed. On discharge and in follow-up clinic, I would also support with the weaning as well of the premature babies. Working on the neonatal unit and part of the MDT and ward rounds, we can adapt our nutritional strategies and prevent feeding complications, which in turn can reduce the length of hospital stay. And this can have a huge impact on our babies and their families as well. I'll probably pass you over to Caroline now, who's our speech and language therapist.
Okay, thank you. Yeah, so I'm Caroline. I'm a speech and language therapist. I've been working in South Tees for coming up to about 17 years, specialising in paediatric dysphagia or eating, drinking and swallowing, mainly in community. But then we've been working more and more into our inpatient settings as well. So we got our funding to start into the neonatal unit at the end of 2018. So we've been part of the neonatal unit for just over 7 years. And I can say that being able to meet the babies and families right at the start of their journey and to work proactively to prevent later problems has just completely changed our community caseload. We used to meet families once feeding problems had become really difficult. Maybe the baby had been very poorly or feeding wasn't just working. Maybe parents might have been exhausted or stressed, or maybe even in crisis with the baby losing weight and having to be admitted onto the wards for tube feeding. But now, working in the neonatal unit, we can assess and support the development of feeding skills, so breast or bottle feeding, right from the start of that feeding relationship and that feeding journey. So we work a lot with families and parents, giving them lots of information and really empowering parents to understand their baby's feeding behaviours and cues. And for more complex babies or babies that have been poorly, we get to assess their feeding skills and to manage and support any risk of aspiration or feeding challenges before they go home. So we really are working proactively on any feeding challenges rather than reacting to them later on down the line. Where we can, and if funding allows, speech and language therapists also have a role in communication, and we might get involved with projects that would support the communication environment of the unit. So babies born early can be at high risk of developing later difficulties with speech and language skills or social communication, which again can have a big impact on their later outcomes and their education. So we aim to support the early development of communication relationships and just enhance the communication environment where we can. I'm going to pass it over to Jo to talk about psychology.
Hi, I'm Jo. I'm a clinical psychologist, and I'd say I'm probably the last one in on the team. I've been here for just over 2 years now, actually. We are a specialist healthcare professional that assesses, diagnoses and treats mental health conditions. We support with emotional distress and complex psychological needs. We also support staff teams as well, where we can, as well as contributing to clinical pathways and service development. An example of that might be about helping services to become more trauma-informed. So on the neonatal unit, psychologists will look at ways of which we can help with families to adjust to being here and help with coping. So some of those might look like helping families to make sense of being on the neonatal unit. We might look at ways to help them cope with their emotional distress. We will think about managing the impact of their experiences on their relationships. So this might be their family or with the neonatal unit team. And then we would look at the family's own strengths and what support they might need with their problem solving skills, And then we'll think about the relationship parents have with their baby and how we can support them there as well. So it's a very busy job with lots of ways that we can offer support to the families and to the wider team as well. So I'm going to pass you back to Lynn.
So one of the questions we get asked is, because people often don't know that physios, OTs, dietitians, psychologists, speech and language therapists are on a neonatal unit. What do we do with these little tiny babies? And we are really trying to promote that for people that are coming up and through the profession, because often these are quite new roles. To work in this field, you need to be highly specialist, and it's really essential that we bring with them a wealth of experience and understanding the complex areas we might cover. So we can't just know about tiny little babies. We need to know about how that impacts them in their life and their journeys going forwards. And we really need to have an expert understanding of child development from conception right through to adulthood. We need to be skilled and experienced in dealing with complex medical uncertainty. Our babies' families, this is often a really new, challenging situation, or they might have found out when the baby was in the womb that there's going to be difficulties, but until they're born, you might not really understand what those challenges might look like. So we need to be empathetic, we need to be really patient, and we need to be really, really flexible. And we're often working with families with all sorts of diverse needs at a time of the most stress they'll probably ever have in their lives. So most of us come from a background of either working in hospitals or working in the community, but we have to have an understanding of both, because we need to understand what these babies have gone through and will go through. Most have been through band 5 rotations, then get experiences as band 6s and 7s in paediatric care. And if you're interested and are able to try, you need to try and access a paediatric rotation. That can be really challenging. So if that's not possible, you might be able to request shadowing, although we can't have hundreds of people coming all the time. But if this is really what you want to do, once you're working on the unit and you get this role, you need to undertake specialist training, because paediatrics is a brilliant base, but there is lots of additional need on top of that. There is lots of different avenues you can go to get that. And in the background, there's lots of work being done on enhancing people's opportunities even further. You've really, really got to be flexible, and you've got to be able to work autonomously, as this is quite an isolating role. You're generally the only person who understands your professional role within the speciality of neonates. So your physios often can't help you if you are a physio, and your medics and nurses can't help you because they are not your specific profession. And I think that's why we all work really well together. There's an overarching support structure which is called the Neonatal Network, and Caroline and I both work as part of that network as well as leads in the speech and language and physio. And what this network aims to do is to improve and standardise, using up-to-date evidence-based practice, the journeys for babies and their families. Lots of these babies that we see move across several units throughout their care, and that can be really challenging and unsettling for families as well. So we also act as profession leads to support staff, work on improving staffing numbers in all the units, as we are pretty underfunded, and work to promote our profession at a local, regional and national level. So it's quite an exciting role, and just another avenue that people might have if they didn't want to stay clinical practice throughout their entire career. But going on from that, we just wanted to mention the MDT because we've all come here together for good reason.
Absolutely. So as AHPs in psychology, we are absolutely strongest together, and we love working together. We're a really good little tight team because absolutely we share a very common core role in protecting our babies' brains and supporting our families and protecting them to improve their later outcomes. So apart from our speech and language post, we didn't have any designated funding for AHP or psychology within the neonatal unit until 2023, so quite recently. And then that funding was secured through the government money following the Ockenden inquiry, which identified a lot of systemic risks across the country within maternity and neonatal care. So all of our roles within the neonatal unit are part-time, and we are all significantly underfunded when we look at benchmarks of things against the Getting It Right First Time national standards. So we are all underfunded against our bandings, our hours, and the responsibilities for such a complex specialist role. So we are unfortunately limited in what we do offer to the unit and what we can offer to babies and families. But we are all, I feel really blessed and really lucky to work with the colleagues that I have, because we are highly motivated, we're very passionate, and we're all committed. We see the difference that our work, our proactive work, makes to improving the care for these babies and families going through a really traumatic time. So we are always advocating for our professional role and making sure we have a positive impact. It can be challenging. We're a new group of professions in neonatal units. It's a very established area of care and a very established team. And it's an environment which is obviously based on that medical model of care, where there's a lot of intensive care going on, which obviously is really important. But as therapists that have that longer viewpoint, sometimes it can be challenging to try and improve practice while embedding our roles and making sure that we're bringing our medical and nursing colleagues along with us and along to understand that longer viewpoint that we might have. So the support that we provide each other has been invaluable, I'd say, for all of us, for enjoying our roles, for sharing our challenges, and just those little moments in the corridor where we have a quick hug or a smile or a catch up. And the support we provide each other is just absolutely invaluable and keeps us all smiling. We understand our different roles, and we are often each other's biggest advocates in the team. Thought we'd finish with a little bit about why we all particularly love our jobs and the little moments that really make it worthwhile doing. So, Lynn, do you want to start?
Basically, I love working with the families, and I really love seeing the positive outcomes we have when our little ones achieve milestones that they may not have managed without our input, especially when a parent brings them on the unit just to show what their new skills are and to see how proud they are to show this to you. And that might be babies who have gone on and have absolutely no difficulties at all, or it might be our really complicated babies who've got real challenges, and they sit up, they smile, they feed themselves for the first time, something that's really massive for those families. And I love seeing the amazement on a parent's face when they can support their baby during something, perhaps a care that was happening that the baby would have been upset for before. And then we give them a little bit of support and that baby's really calm and settled. And that's a magic moment for babies and parents. I'm going to again speak for Emma, if that's okay, who's our OT. What she wanted to say is that parenting on the neonatal unit may look very different to typical parenting. And the experience for a baby staying on the unit is really different to a baby who goes home straight away. So she loves being able to support both the parents and the babies at this really stressful time. And it means such a great deal to her. She loves the fact that something as simple as going through an alternative nappy change with a parent and their baby, and them commenting on how much calmer the baby is, has such a huge impact and really makes her feel worthwhile. Jess, back to you.
I think I just feel privileged to be part of such an amazingly professional and passionate team and to be involved with so many babies and their families. I think it makes a difference to the families if you may continue to follow up post-discharge from the neonatal unit. It's important that you know their baby's story and you know their background and the battles that the babies and the families have overcome. And then when you can see a baby progress and thrive and the confidence of the parents, I think that's the more rewarding thing that you get. And I think that's the best thing that I love about my role. Caroline, what do you think?
I would say I think some of my favourite moments are when I've been working with a family on supporting feeding relationship and then just actually being able to step back and step out of that experience and see a new mum or a new dad and see them watching and understanding their baby and being able to support their baby moment to moment during a feeding experience, seeing that feeding partnership and seeing that love between that new parent and that baby and just seeing that take off is just a moment that always brings me a lot of joy. Absolutely. And those little moments really keep us going. Jo?
For me, I would say it's probably the relationships that I build with the families. I really have met some really wonderful, wonderful people. And it feels a little bit different to other places that I've worked. So I've worked in I worked in CAMS previously. And I suppose here you get to see the families more often and in different ways as well. So I might see them sort of therapeutically on a more sort of traditional, formal therapeutic session. And then I might see them in the corridor. I'll pop down and see their baby and see how they're doing. And so you just build some really, really lovely relationships with everyone. And it just feels like that continues as well. So we had a Christmas party last year and families came back and we got to see everyone again and how everyone was doing. And it was just really, really lovely to see the families thriving together. And it was a little moment of joy for us, wasn't it? Of just seeing how everyone was doing. And it was really, really lovely.
But we're really happy to share our emails and happy to be contacted by anyone that wants to get in touch for more information. And particularly from a network perspective, there's a lead for every profession in that network, and anyone who really is motivated to think about neonates, please get in contact and we can help guide and support. Thank you very much.
Thank you.
Thank you for joining us. Till next time, you've been listening to T's Voices.